It gives me a great pleasure to introduce my next speaker, Dr. Ahmed Ameen, a specialist in dermatology and immunology. He works in NMC Specialty Hospital, Abu Dhabi. He participated in many clinical trials as a principal investigator in psoriasis, atopic dermatitis, and acne, with many publication posters and abstracts in international journals and conferences. Dr. Ahmed is an international fellow of American Academy of Dermatology and European Academy of Dermatology and Venereology. He's also a member of many dermatological societies as an international Dermoscopy Society, Emirates Dermatology Society, Emirates Medical Association, and Saudi Society of Dermatology and Dermatologic Surgery. So, Dr. Ameen, the floor is yours, and it's a pleasure having you with us. Thank you for coming.
Thank you, Dr. Muhammad, for the kind introduction. Good afternoon, my colleagues. It's really a pleasure to be with all of you today. My talk will be atopic dermatitis. We have a new molecule, and once we have a new molecule, we're having a new hope that we can add something to our patients. That's my disclosures. So my objective today will talk about the burden of the disease, how atopic dermatitis can really affect our quality of life for the patients, which patient is for which therapy, who will be eligible for the systemic therapy, and we need to highlight the story of atopic dermatitis, the pathogenesis of the disease and the treatment options that we have today. And today I'm introducing aprocitenib as a new molecule in atopic dermatitis treatment. What's the journey of the success of this medication in terms of clinical trials when it comes to efficacy and safety data, and how to start our next patient on aprocitenib. Before starting, we have a very few questions that we need to answer it together, and basically the answer will be discussed in our presentation. While we have a new molecule in a disease like atopic dermatitis, all of us will be differentiated in 3 different groups. Some of us will be excited to start from the first day and try the new medication. Others will wait until hear about the medication from the others. So sometimes I will not be the first doctor to start a new medication. And in the era of atopic dermatitis treatment, some of us will stack that I am happy and satisfied with the current treatment options. So there are 3 different messages for the 3 different group of doctors that everybody will have his own concept. I will start from day 1. I will wait a couple of months, 3 months until I will see how it's worked, or I don't want to take one step up, whatever the treatment option, because I'm happy with what we have today. While reading the data of any molecule in atopic dermatitis, we have to look for the efficacy, for the safety, for the onset of action of the medication, because we are talking about disease with a very high severe burden. Cost is almost considerable, and route of administration. How is this medication will be compliable for our patients? Is it easy or not easy? I want to ask one question for all of us. Are we today considering JAK inhibitors as a treatment option for atopic dermatitis or not? Because we have 3 licensed JAK inhibitors in atopic dermatitis treatment today. We have upadacitinib, baricitinib, and recently aprocitenib also. So we have doctors who still believe that, yes, I should consider this treatment option because it shows difference in terms of efficacy and also in terms of safety or not. But we still have some other doctors who do not want to start with JAK inhibitors in atopic dermatitis. So for them, I'm asking the next question, why? So some of them, maybe they will say, I will not have a patient who is eligible because he's thinking that these medications are licensed for the very, very severe patients. But the very important message that all the license of the systemic therapy that's available today is for the moderate to severe atopic dermatitis patients. Others, as we mentioned earlier, will be happy with the current treatment option, and others have some safety concerns. So that's why we are here today. We need to simplify the safety data that we have for the JAK inhibitors. We need to compare it with the others to know where we stand in terms of safety. So if we start to talk about atopic dermatitis disease burden, I prefer not to share data and graphs and percentages. I just need you to visit my clinic to see how our patients are really suffering from the disease of atopic dermatitis. It's not a matter of itching. It's not a matter of just skin clearance. We are talking about a quality of life impact if we have patients like this in our home. It's really, really be different to be part from any community to do any social activities while we're having a disease with the bad faces like this in the teenage, 12, 13 years old, she will never be a normal kid. She will never attend the swimming classes. She will take very long time to choose her clothes. It's a very, very difficult. While we have a family member with atopic dermatitis with a very severe pictures like what we have. Hand eczema is always up categorized as a severe disease because of it's really affecting all the quality of life, all the daily activities. This patient came in the first visit on a wheelchair. We can imagine how is the situation that the patient left because of his severe eczema. All of these manifestations, all of these pictures, all of these symptoms, itching, dryness, lichenification, definitely have an impact on the quality of life, and all of this will share together to affect the patient psychologically, and we will affect his quality of life negatively. All of us aware with the complication of atopic dermatitis, atopic comorbidities, increase the susceptibility of the infections, increased incidence of other autoimmune disease, ocular complications, keratoconjunctivitis, keratitis, and again, reduce the quality of life, sleep disturbance, anti-anxiety medications. All these are bad phases of atopic dermatitis. We know that there is an increase in the incidence and probability of all the autoimmune associations and comorbidities when talking about other Th2 manifestations like asthma, blood pressure, food allergy, heart disease, autoimmune disease. Atopic dermatitis patients have an increased incidence of everything if we compare it with the other patients. So that's why these patients, really we need to treat them as soon as possible, aggressively with the strongest medication that we can to control the quality of life for the patient, not only as an anti-itch medication. That's a very important point. When it comes to the economic burden that we need to just understand the concept that how is our community, our insurance companies, how all these are really suffered from the cost of the disease. If this disease is not going to be controlled. If we see that as per a US study, more than $5.7 million have been spent in only 1 year, either as a direct cost for a medication, for a hospital visit, for an ER visit, or as an indirect cost when it comes to presentism and absenteeism. So we have a huge amount of money will be spending in atopic dermatitis patient if this disease is not going to be controlled. If we compare what happened in just 10 years, we have more than 100%, double the cost have been increased because of the non-control of the disease. A very important question: who is eligible for systemic therapy? As we learned earlier, the patient who have an eczema from head to toe, that's the patient for the systemic therapy. But after that, we start to understand that the criteria of severity is really changing, because all the medications that we have today, either monoclonal antibodies or JAK inhibitors, are licensed for moderate to severe atopic dermatitis patients. So who is the severe patient? What's the criteria of the severity? Yes, lesional severity is very important. If you have a periocular dermatitis, perioral dermatitis, hand eczema, which is making a direct impact on the quality of life, I should not respect to the body surface area in this situation. This kind of patient should be up categorized to severe patients. Definitely extent of the body surface area is considered a severe patient. If I have a generalized eczema, 100% for sure that this is a severe patient. Impact on the quality of life with the specific lesional severity, the patient do not have a generalized eczema, but he cannot stop the topical treatment. He is in the hassle of topical application every day and night, and this is definitely affecting his quality of life, affecting his mood, affecting his behavior. So I should up categorize this patient to be a severe patient. If we have a patient with another association of 2H2 manifestation or with an incidence of complications, so this patient should be considered as severe patient. I have one patient every year, 2-3 times attack of eczema herpeticum. However, he don't have a generalized eczema, but in this situation, I should consider him as a severe patient. What's the story for atopic dermatitis? I know that all of you are expert in that. We need to just make a little summary about the story from the beginning, which is the barrier dysfunction that all of our patients have, and this will help to penetration of the allergen through the impaired barrier. Once this allergen has been penetrated, the dendritic cells have been activated, naive T cell have been differentiated to the Th2 cell, cytokines will start, the bad guys will start to be secreted, IL-31 as an itch moderator, IL-4 and IL-13, and then we'll start a cycle of the itch scratch cycle. Once the patient starts to itch, the lichenification will start, barrier disruption will be more and more because of the severe itching, and then we will start a stage of chronicity with a thickened skin, with another key players and another activation of other Th22 and Th17 and Th2 also will start to increase another cytokines, which increase the keratinocyte hyperproliferation, K16, which is a moderator for the hyperproliferation. Skin will start to be psoriasiform-like thick skin to compensate the barrier disruption that we have. And again, Th1 have another role in the activation of the chronic disease. So if we need to treat atopic dermatitis, we have to search about these key players and we need to control it. The pharmaceutical companies start to think either by blocking one or two cytokines, and this is how the monoclonal antibody is working. Either we have IL-4 and IL-13 blocker now. We have two IL-13 products. We have IL-31 ongoing trials. These are the monoclonal antibody. Or the other ones is to make a broader level of blocking, which is the concept of the JAK-STAT pathway, that we can block more than one cytokine in the same time. So if we need to control the disease activity, we have to block only one key player, which is the monoclonal biologics, or a broader blocking. I will increase the level of blocking to block more than one cytokine in the same time, which is the JAK inhibition. So what is the treatment paradigm that we have for atopic dermatitis? Still 2018 is different than what happened after that. Before the 2018, we have a very limited options when it comes to topical treatment, either steroid or calcium inhibitors, adjuvant therapy like the phototherapy, systemic treatment. The only labeled medication was dupilumab. But what's happening in you after 2018, we got an approval for a topical treatment after so many years, which is crisaborole, which is a Stiquus as a BD4 inhibitor, which is working topically for the mild to moderate atopic dermatitis patients. The most important thing that crisaborole is not a topical steroid, is not a calcium inhibitor. It controls the BD4 overactivity because we have a belief that the BD4 increased in our atopic dermatitis patients. How it will work through reduction of the BD4, inhibiting of the BD4, and this will inhibit some inflammatory cytokines which have an impact on the disease progression. These are the bad guys that while we're applying the topical ointment on the skin, we are reducing these inflammatory markers, and subsequently the disease progression will be less. It's a very simple ointment. We'll apply it as a twice daily from age of 2 with a very, very limited number of the side effects. At age of 3 months, we can start to apply as a twice daily. So that is the only innovation happened in the last 10 years when it comes to the topical treatment. What about the systemic treatment? As we know, the evolving landscape of the atopic dermatitis treatment, we have now 5 treatment options or a license as a first-line systemic therapy for our atopic dermatitis patient. We have dupilumab, which is approved from age of 6 by all the labels, EMA label, FDA locally. We have tralokinumab approved locally and approved by EMA in atopic dermatitis patients. FDA is still going on. We have lebrikizumab, which is IL-13 is still ongoing. We have nemolizumab, IL-31 is still, the trials are going. And we have 3 JAK inhibitors, all the 3 approved locally, baricitinib, upadacitinib, aprocitinib. The UPA and the aprocitinib approved by the EMA and the FDA, but baricitinib only approved by the EMA. So our pocket is full of the medications that we need to understand which is for which, and we need to understand the difference, and we need to choose for our patient the best treatment option that we have. But the question is, do we really need the JAK inhibition in the treatment paradigm for atopic dermatitis or not? Do we have any unmet needs today that the current treatment option is not able to 100% close these unmet needs or not? EASY 90 and EASY 100 is a very difficult target to be achieved with the current treatment option because the target is EASY 75 today. But if we have a medication that have a nice data about this high level of itch control, improving of all the signs and symptoms of atopic dermatitis, definitely it will add something to us. IgE 0 to 1, which means the disease is almost controlled. The skin clearance, the concept of most of our patients have a clear skin, is a really difficult target to be achieved with the current treatment options that we have. Injection phobia, we have not limited number of patients that will not accept any systemic treatment because of the injection phobia. Route of administration, the patient sometimes prefer the easy medication, which is a tablet can be given once daily, anytime, before, after food, anytime, so they will be happy with this treatment option. We have a new concept with the JAK inhibition, which is itch improving within days. We have some patients, 1 or 2 days really matter. in terms of quality of life. He have exams, he have a wedding, he cannot sleep at night. So itch control within days is a difficult job for the current treatment option. And we need a prescription with only one medication, because the current treatment option is very difficult to take the topical steroid away. But now we have a monotherapy data of only one medication can achieve the needed. So that's why we need a treatment option to overcome all these unmet needs, and we'll never forget the patients who do not respond. So patients who do not respond, who are not happy on the current treatment option, who's not well tolerated, who's poorly responder, we can start to consider the other treatment options that we have. So what's JAK inhibition? We have 3 molecules, as we mentioned: paracetamib as a JAK1, JAK2, aprocitenib and upadacitinib and JAK1. The difference between apro and UPA is the level of blocking. This is blocking JAK1 more than JAK2, more than TYK3 and JAK3. The other one is JAK3 is more than TYK2. How it will work? It's a very, very important point. We have an inflammatory marker, whatever which cytokine, either IL-4, IL-13, IL-31, TSLB. This inflammatory marker have an inflammatory message need to be transferred to the nucleus to start the inflammation. This message cannot be transferred without a courier. So who is the courier? Will carry this inflammatory message through the cytokine to inside the nucleus to start the inflammatory process. This is the JAK-STAT. So the JAK-STAT pathway is taking in a closed envelope an inflammatory message from the cytokine, go through the receptor to the nucleus, start an inflammatory process. If we can stop this courier to work, maybe we'll be able to stop the inflammatory message, so we'll make a disease control. And that's what we can see here. So this is the cytokine, IL-4, 13, 31, whatever who is he, will attach to the receptor extracellularly and have an inflammatory message in his pocket, searching for somebody to carry it inside the nucleus. So the JAKs will start to be activated, will start to be phosphorylated, and once the JAKs phosphorylated through the STAT pathway, so this is STAT, which is standard for signal transducer and activator of transcription, will carry the message, will take the envelope from the cytokine, and will leave the receptor, and will go down to the nucleus, transferring this inflammatory message. Once it will go to the nucleus, the process of inflammation will start. So the concept here, if we understand this concept, we'll know what will happen in atopic dermatitis in the next 5 years. We need to prevent this pathway to happen. We need to stop the inflammatory message to be transferred from the cytokine to the nucleus, so we will control the disease activity, and this is how the JAK inhibitors will work. Today, as I mentioned, I will introduce aprocitenib in terms of efficacy and safety. Is a JAK1 selective inhibitor, so it's an indicated for treatment of moderate to severe atopic dermatitis patient who is aging for 12 years and above, as per the local license that we have here. So we have 100 milligram or 200 milligram. We can start with any of the dosage, but the standard dose is a 200 milligram, and 100 milligram can be considered in the adolescent or the age more than 65 years. And we can start with the 200. Once we control the disease, we can go down with the dose 200 milligram. We have a very big clinical program. We have different clinical trials for aprocitenib, starting with the JAD Mono 1 and 2, which is only evaluating a monotherapy treatment. And we have a JAD Compare, which is adding an active comparator in the study, which is dupilumab. And we have the JAD regimen differentiating between the different doses, stopping and retreatment and withdrawal. Another studies, which is the JAD teen, only for the adolescent. And we have a long-term extension data. So we will not go through all these today. We will start with the JAD Mono 1 and 2, which is only evaluating aprocitenib as a monotherapy treatment for the moderate to severe atopic dermatitis patient who is more than 12 years. They are comparing the 100 milligram dose, 200 milligram dose, and the placebo arm. So what we have here in a 12 weeks, we have a different data that we used to see before. We are only talking about different few days as a change in the baseline. And when it comes to the EASI-75, we have a 60% or more achieving EASI-75 response within only 2 weeks. We have, as per the JAD2, we have 60 to 62% of the patient achieved a high level of disease control. And this is again within only 12 weeks. EASI-90, now we start to see that data of EASI-90. This is the unmet need that we are talking about when we talk about the other treatment option, because we have at least about 35 to 40% of the patients achieve EASI-90, means that 90% control of the disease if we compare the current situation with the baseline reading. And this is a very difficult target to be achieved in the past before the introduction of JAK inhibitors. What about IgE 0 to 1, which is the complete clearance of the skin? We again have 40% of the patients within 12 weeks will be completely controlled in terms of efficacy. What about the itch relief? Within days, within week, we have more than 50 to 55% of the patients, they achieve itch control in the night pruritus scale more than 4 points. And this is, again, if we compare it with the before, is a very difficult target to be achieved. And the interesting here that we are seeing data even from the week 2. We are seeing a difference in the fast onset of action to achieve this target. So it's not only itch control, but it's a fast itch control. What about JAT compare, which is comparing the aprocitenib 100 milligram to 100 milligram placebo, and there is another arm for the dupilumab, but it's not a direct head-to-head study. Dupilumab have been added here as a direct comparator, active comparator to compare only the itch relief within the first 2 weeks. So we have, again, in terms of EASI-75 and Ig 0 to 1, a very high number superiority of the CPINC, which is aprocitenib 200 milligram, as we can see here, more than 70% EASI-75 improvement, and IgE 0 to 1 more than 48% achieved with the high dose of aprocitenib in only this 16 weeks. And if we see the curve of dupilumab is lower significantly than this. What happened with EASI-90? Again, we have 46 to 47% of the patients achieved this EASI-90 with the high dose of aprocitenib, and there is a 35% of dupilumab achieved the EASI-90 within the same duration. What about the active comparison here? Itch relief in 2 weeks, we have a superiority of aprocitenib versus dupilumab when it comes to itch relief after 2 weeks, 62% versus only 57%. So what's about the safety profile? We have a comprehensive clinical trials, more than 60 clinical studies, and they are highlighting that based on this data, we don't have any unexpected safety signals if we compare aprocitenib with the other JAKs. We have only one signal, which is common in about 10% of the patients, which is the nausea. The other side effects have been reported in less than about from 1 to 10% of the patients, which is herpes simplex, nausea, headache, and vomiting, and acne, and increasing the CPK. And these are the signals that relate to all the class of the JAK inhibitors. So what we have only here is one signal for the nausea, and it was mostly a dose-dependent report, and most of them doesn't lead to the discontinuation of the treatment. If we will see the incidence between the 100 and 200 milligram, we will see some dose-dependent signals, as we mentioned, like the nausea, like the acne, like the herpes simplex, but all these are comparable with the other safety data of the JAKs, or even sometimes better than the others. When we need to simplify, if we talk about the infection, again, we have an incidence of herpes simplex, herpes zoster, which is little bit dose dependent, but when we talk about serious infection, it is very, very limited number of patients. What about malignancies? We're almost talk about nothing, 0.2, 0.3%, which is maybe the main same percentage that we have with atopic dermatitis patients. When about cardiovascular events, because we have a little concern with the JAKs, with the pulmonary embolism and DVT and major adverse cardiac event, but what we are talking about here is from 0.3 to 0.4%, and there is no dose dependence increase in this risk that we have. So we have, again, a very limited number, not exceeding 0.5% of the patients. Lab abnormalities have been reported, starting with the thrombocytopenia. It took about 4 weeks until it come back again to the normal, but again, it doesn't lead to discontinuation of the treatment. Again, it's have been reported in 0.1, 0.3% of the patients. So again, is it significant or not significant? The percentage is very important to have a look in it. The discontinuation rate, again, is very important. Lymphopenia have been reported in 0.1 to 0.3% of the patients, transient, come back after 4 to 6 weeks. Lipid elevation have been reported in 0.4 to 0.6 of the patients. So that's why we need to follow up after 4 weeks and after 12 weeks to check. And the CPK increase, especially in the teenage who is going to the gym, he's playing sport. But again, the percentage is from 1 to 3% of the patients. How to start? My last few slides. Any patient more than 12 years old with a moderate to severe atopic dermatitis is licensed for aprocitenib treatment. Can be taken as a once daily medication. It's very important to understand the the dose can be reduced based on the efficacy. After you maintain the response with that 200, you can go back to the 100 milligram, can be taken with or without food. And very important to understand that can be taken with topical steroid or without. Contraindication, do not start if you have a patient with a serious infection. That's like all the other class of the JAKs. Hypersensitivity, pregnancy, we don't have data. Breastfeeding, we don't have data. If we have a severe hepatic impairment. What we need to know about the serious infection, if we have a serious infection, that's all for all the class of the JAK, that we need to interrupt the medication. TB, we need to start an anti-tuberculosis medications and prophylaxis before starting. Vaccines should not be given during the treatment, and we should, especially the live vaccines, we need to stop for 1 week before and after. Viral activation, if it has happened, again, we need to stop the medication and we need to consider interruption of this. What we need to do, we have to repeat the CBC and the platelet count, lymphocytic count after 4 weeks of the treatment. Lipid profile also should be examined after 4 weeks, because as we mentioned, the peak is after 4 weeks before it comes down. So better to take a baseline reading and another reading after 4 weeks. If I need to summarize, atopic dermatitis is a disease with a significant burden. As you know, the pathogenesis is a little complicated. We have so many key players in terms of disease activation. Biologics are monoclonal antibody, considering only 1 or 2 molecules. JAK inhibitors are working broadly to block more than one cytokine in the same time. Aprocitenib, Cibinqo is a selective JAK1 inhibitors, recently approved for moderate to severe atopic dermatitis patient more than 12 years, who is candidate for a systemic therapy with a good efficacy data and acceptable safety profile. The safety profile has been established from more than 6 clinical programs, and it's comparable with the other JAKs. With that, I'd like to thank you very much for your attention.